Next on the runway, we have Dr. Deepti Harshavardhana, and she will be presenting on implantable devices in surgery. So Dr. Deepti Harshavardhana is an assistant professor at the Thomas Jefferson University Hospital. She completed her medical degree at Rowan School of Osteopathic Medicine. She then did her anesthesiology residency that followed by a regional and acute pain medicine fellowship at Thomas Jefferson. And obviously, she also then stayed as a regional faculty. Please welcome Dr. Harshavardhana.
Good morning, everyone. Thank you for that introduction. Yes, so I will be talking about how we're supposed to manage these various implantable devices that we keep seeing patients come in with for surgery. So these are my learning objectives. Okay, so with advances in cardiology and cardiothoracic surgery, several newer implantable cardiac devices have become a commonplace in the surgical population. And the rapid evolution in the field necessitates recurring updates to the clinical guidance on the peri-procedural management of these devices. And these are the types of devices we commonly see: permanent pacemaker, which is used for problems with the conduction system; AICDs, or artificial implantable cardioverter defibrillators, which are used for treatment of life-threatening arrhythmias; and then cardiac synchronization therapy, which can treat heart failure. So all cardiac pacemakers consist of a pulse generator, which provides the electrical impulse from a battery power source that's commonly implanted in the anterior chest wall, and one or more electrodes or leads that deliver the electrical impulse from the pulse generator to the myocardium. And the AICD system comprises three elements: pacing and sensing electrodes, defibrillation electrodes, and a pulse generator. So just to review the nomenclature, this was standardized. So the position 1 reflects the chambers that are paced, position 2 reflects the chambers that are sensed, and position 3 refers to how the pacemaker responds to a sensed event. So O indicates the device will pace automatically at a specified rate, and it'll ignore any intrinsic rhythm. I indicates that a sensed event inhibits the output pulse. T indicates that an output pulse is triggered in response to a sensed event, and D indicates that you'll have dual modes of response, and it's restricted to dual chamber systems. So understanding the details and characteristics of the proposed operative procedure, along with the specific device features, is vital, particularly in patients who are pacemaker dependent. So oversensing of electromagnetic interference, or EMI, may result in failure of appropriate pacing output or false detection of arrhythmias. And monopolar cautery is the principal source of EMI. True bipolar cautery is safe and has no adverse effects. And the use of electrocautery below the level of the umbilicus is associated with lower risk of EMI procedures than procedures above the umbilicus. So this table shows some of the procedures that can interfere with cardiac devices. Some that I found interesting: therapeutic radiation can result in device reset. The TENS units can sometimes cause EMI as well, and lithotripsy can cause a reset. And these are some of the recommendations to avoid EMI. You should keep the current path away from the device by placing the return electrode on the contralateral lower limb. Use bipolar electrocautery whenever possible. And if using monopolar electrocautery, limit the burst to less than 5 seconds. And low battery of the device increases the risk of electrical current intrusion. So what about a magnet? A magnet is used to suspend anti-tachyarrhythmia functions of an AICD or to produce asynchronous pacing in a permanent pacemaker. But the routine use of a magnet is actually not encouraged. When a magnet is applied to a permanent pacemaker, asynchronous pacing will be initiated no matter what. And when placed on an AICD, the anti-tachyarrhythmia detection is suspended, but not the pacing capabilities. So since a magnet cannot initiate asynchronous pacing in an AICD, EMI can result in bradycardia or asystole. And other disadvantages include ability to maintain the position of the magnet in like the lateral or prone position, depending on the surgery, possible compromise to the operative field sterility, and the presence of surgical drapes can interfere with it as well, with access to it. So it's essential also to identify the manufacturer of the device before any procedure, because each device manufacturer may have different functionalities or susceptibilities, and that's what this table shows. I won't go through all the details here, but for instance, the subcutaneous ICD made by Boston Scientific has no bradycardia pacing when you apply a magnet. So this is a nice diagram to kind of show a decision pathway that you can use for cardiac device management preoperatively. And so just start with, at the top here, see where the surgical site is. If it's above the umbilicus, then you can check if the patient has a defibrillator. If yes, then you should disable the ICD therapies. Then you should decipher if the patient is pacemaker dependent. Now, they have defined pacemaker dependent as patients who have a pacing burden of greater than 40%. And AOO, VOO, and DOO are the asynchronous pacing of the atrium, ventricle, and both atria and ventricle, respectively. And remember, reprogramming is required for defibrillators because of the lack of asynchronous pacing. So what about non-cardiac devices? So we're encountering patients with these devices with increasing frequency. These are known as neurologic stimulators and include, but are not limited to, spinal cord stimulators, deep brain stimulators, vagal nerve stimulators, and phrenic nerve stimulators. So prior to anesthetizing a patient with one of these non-cardiac implantable devices, there are several questions that you should be asking. Identify the type of device, the manufacturer, the model. Does the patient have their device identification card with them? Where are the leads? Where's the pulse generator? How do you turn this device off? How do you inactivate it? Does the patient have a remote? What happens when you turn off the device? When was it last interrogated? Is there a safe mode for surgery or for MRI? Some other questions as well. So patients with these devices undergoing surgery with electrocautery are at risk for harm. So these risks can be mild, such as potentially reprogramming the device and changes in stimulator output, but there's also significant risk of harm, including thermal skin burns, damage to the electrode, failure of the generator, or thermal injury to the underlying neurologic tissue. And due to these greater risks, manufacturers recommend avoiding the use of electrocautery altogether. But if it is necessary, then they recommend to turn the device off. And like I said in the previous slide, some devices have a surgery mode available, which can be a safe option as well. So regional neuraxial anesthesia can pose challenges in patients with these devices. And any upper extremity block in a patient with a DBS or cranial nerve stimulator should be performed under direct visualization with an ultrasound or fluoroscopy. And the use of peripheral nerve stimulation to identify the location of the brachial plexus should be avoided as well. But neuraxial anesthesia in patients with spinal cord stimulators can be performed, but it's important to review imaging to identify the location of the leads, the level of insertion, the extension of the wires, and the internal pulse generator. And it's imperative that the neuraxial placement occur below the level of the spinal cord stimulator to avoid transecting it.